Welcome to the module on neck pain and associated disorders. As I go through the module, I'm going to bring forward a very short case example, and as I discuss new conditions, I'll discuss some progression within the case. So there's a 65-year-old male who presents with neck pain and developed 2 weeks ago. They report mild improvements with no specific mechanism of injury, and aggravating factors include extending their head, which recreates the chief complaint, as well as some difficulty driving due to limited range of motion. When we think about neck pain, globally, it's a leading cause of years lived with disability. And from 2020 to 2050, it's expected that the cases of neck pain globally will increase significantly. Now, there's different causes of neck pain, and there's different buckets that we can think about when it comes to the conditions. Mechanical neck pain or non-specific neck pain and associated neurological conditions such as cervical radiculopathy and degenerative cervical myelopathy, as well as specific pathology, such as vertebral fractures, axial spondyloarthritis, malignancy, infection, or cervical artery dissection. When it comes to neck pain and the prognosis for mechanical neck pain, the majority of individuals will report improvements within 6 weeks. And as we see from this figure, that's what happens with the majority, either much improved or fully recovered. However, it's important to understand and know that when it comes to neck pain, similar to the low back, there's various subgroups within the population. Some individuals will be fully recovered by 6 weeks. Others will report much improvement, and others won't improve very much at all and create long-lasting chronic pain. This is where other factors may be at play, such as psychosocial factors, which will be discussed in other aspects of the module. The evidence-based management of neck pain includes education and reassurance, remaining active, multimodal care, manual therapy such as spinal manipulation or mobilization with exercise, clinical massage, psychological therapy for specific subgroups when indicated, and pain medication as needed, such as NSAIDs. Now, if we go back to the case and we think about a progression, this patient now develops unilateral right arm and interscapular pain. Aggravating factors include extending their head and turning their head to the right, with relieving factors include placing the arm over their head. Symptoms are significantly impacting their daily activities. When we think about cervical radiculopathy, we think about various causes of this condition, such as disc herniations, hypertrophy of the uncovertebral and facet joints, and this can lead to inflammation and compression of the nerves, which can lead to significant symptoms down one's arm, for example. The clinical presentation is relatively standard, but it can vary. The majority of people will report neck pain. The majority will report arm pain and paresthesia. About half of people may report interscapular pain. And when we think about also isolated neck, trap, and shoulder pain, about 20% of individuals will report this symptom. So no symptoms going fully down the arm, but only in the proximal aspect of the arm. And this is an important thing to think about, that this can be challenging in clinical practice. Is this a cervical radiculopathy or is this a shoulder pathology? And when we think about history, there's various questions that have identified and explored the diagnostic accuracy of history questions in order to identify which ones have a high specificity. These 4 have a high specificity, including arm pain worse than neck pain, provocation of symptoms when ironing, a reduction of symptoms when walking with the hand in the pocket, and neck movement improving symptoms. Further evaluation of the diagnostic accuracy of these questions revealed, though, that only arm pain worse than neck pain has a high enough positive likelihood ratio to have any meaningful clinical impact in practice. Another thing to think about from the history is the dermatomal distribution. Similar to lumbar radiculopathy, only about 30 to 55% of cases may follow a dermatomal pattern. So similar to lumbar radiculopathy, not all cases, and actually about half may not follow the dermatome that we're expecting based on what we're seeing on imaging or based on what we're seeing clinically. So when we think about the management, we had conducted a systematic review, which looked at the conservative management of cervical radiculopathy. And this was a very wide-ranging inclusion criteria, which included all non-operative interventions, excluding epidural steroid injections. So the risk of bias assessment of the studies that were included, 28 were rated as some concerns, 2 were rated as low risk of bias, and 49 were rated as high risk of bias. So this really is a challenge within the literature that the majority of studies are high risk of bias studies. When we did the analysis, we only included some concerns and low risk of bias studies. So for the some concerns or low risk of bias studies, there's very low certainty evidence for acupuncture, prednisone, cervical manipulation, thoracic spine manipulation, and low-level laser therapy. The majority of the studies evaluated multimodal interventions, and what they found was that there's mixed effectiveness for cervical traction when combined with other interventions, as well as exercise in addition to other treatments may improve pain and disability compared to interventions without exercise. There was also what we found inconclusive evidence for immediate pain reduction when comparing conservative management to surgery. And overall, according to the grade that we had used and the grade criteria, there's very low to low certainty evidence, which means that future research will likely impact the state of the literature for the management of cervical radiculopathy, the conservative management. So when we think about the literature and we think about that there's very low to low certainty evidence, including patient preference and experience is important. We conducted a qualitative study where we asked patients, what do you want from a rehabilitation program of care? And this was the ideal program. They wanted patients wanted clinicians to understand their personal preferences. They wanted individualized care provided. They wanted healthcare providers who were compassionate, reassuring, able to properly communicate their diagnosis and next steps. They wanted access to imaging and specialist care when needed, a collaborative interprofessional care approach. They wanted patient education. They wanted to understand what was going on, and they wanted some peer support to know that they weren't alone in this. As well, when we asked about the outcomes and what they expected from a conservative program of care, they expected that symptoms would be less intense and more intermittent. And when asked about their expectations from surgical care, they expected that their symptoms would be completely gone. When we think about the non-operative approach that we take at clinic, education and reassurance is important. Self-management strategies are important to provide, which we do. Multimodal care, including manual therapy with neuromobilization. Neck and upper back exercises, such as range of motion and strength training. A cognitive behavioral approach, as there's significant psychological aspects related to this condition because of the intense pain and symptoms they have and impact they have to their daily activities, as well as a collaborative care approach. When we think back to the case and some progression, 10 years later, this patient now develops leg heaviness. They have intermittent bilateral arm numbness, they have tingling, and they have pain, and they report electric shocks down their arm. It reports difficulty also buttoning up shirts, but there's no bowel or bladder dysfunction. Now we're thinking about degenerative cervical myelopathy. And degenerative cervical myelopathy, or DCM, is the most common non-traumatic spinal cord injury. The prevalence of spinal cord compression, and this goes back to the discussion with regards to false positives on imaging, is that there was a study that looked at individuals in a healthy group where there was no clinical reason to undergo cervical MRIs. In this asymptomatic population, 24.2% had asymptomatic spinal cord compression, and there was a higher prevalence in the older age group. When we look at the uncertain group where there is some symptoms that could warrant an MRI, but not necessarily pointing towards DCM, such as dizziness or headaches or radiculopathy in isolation, 17.6% had spinal cord compression. And in the high-risk group, where there's signs and symptoms of degenerative cervical myelopathy, 81.3% had spinal cord compression on imaging. The most common initial symptoms in this study that looked at patient presentations and the symptoms that they experienced were neck pain, shoulder pain, pins and needles in the hand, arm pain, as well as the Hermite sign. And when they looked at which symptoms were associated with an early diagnosis, which they defined as less than 6 months from symptom onset, the only symptom significantly associated was heavy legs. And ultimately, there's really a long diagnostic delay when it comes to this condition. And that's a real challenge with DCM. is that because of the signs and symptoms, because there's a lot of different symptoms and signs that may be showing, and sometimes they're very non-specific, and a lot of times they are, there's a long diagnostic delay before they actually receive this diagnosis. This was from a clinical practice guideline, and when we think about DCM and we think about asymptomatic cord compression, mild, moderate, and severe, moderate and severe DCM, according to the MJOA, really surgery, there's a strong recommendation for it. When it comes to mild DCM, there's surgery or supervised structured rehab, and this is a weak recommendation. And when it comes to asymptomatic cord compression and what do you do with these individuals, prophylactic surgery is not recommended, and this is based on a weak recommendation. And the challenge when it comes to this and the progression of DCM is that some individuals will deteriorate. One study found that after a 3 to 6 year follow-up, 20 to 60% of patients with myelopathy symptoms will deteriorate over time, but not everyone does deteriorate. And there was an observational study that looked at asymptomatic spinal cord compression, and the likelihood of developing DCM does increase over time, which makes sense. But after 1 year, 8% of people developed, and after a median follow-up of 44 months, 22% of people developed. The challenge is it's difficult to determine who will progress and who won't. Radiculopathy may be a risk factor for DCM development, and this really is where the challenge comes is what do you do with individuals who have mild DCM, for example? When we look at the non-operative management of mild degenerative cervical myelopathy, there's low-level evidence that non-operative treatment for patients with milder DCM have similar outcomes compared to surgery, and this is from a systematic review that was conducted. And examples of non-operative management in these studies included intermittent bed rest, use of a collar, discouraging high-risk activities, medication, traction, physical therapy, but there really are a lot of limitations with the current studies. A lot of the studies are cohort studies rather than RCTs, as well as studies comparing surgery versus non-surgery. The more severe forms of DCM typically will receive surgery in these studies, and the more milder forms will receive non-surgical interventions, as well as there's selection bias of participants in these studies. When it comes to individuals who receive surgery, so if they receive surgery for moderate or severe DCM or even mild DCM, when it comes to the rehabilitation, pre and post-operative rehabilitation is an area that is currently being investigated further. Currently, there is limited literature in this, but the thought is that incorporating aerobic, range of motion, and stabilization exercises, balance, and gait-specific interventions can be helpful, and it's important to evaluate and treat on a case-by-case basis. There was a study that looked at early post-operative rehab compared to delayed rehab, which they defined as rehab within 6 weeks following surgery, and this led to greater improvements in 12-month physical function outcomes. So early post-operative rehab as well as preoperative rehab is likely to be beneficial, but further research is needed. What's the non-operative approach that we take in clinic? And it includes education, self-management strategies, multimodal care, including manual therapy, no cervical manipulation, manual therapy as well, including neuromobilization, neck exercises such as range of motion and strength training, exercises that target patient-specific needs such as balance, so really identifying and individualizing their treatment, a cognitive behavioral approach, as well as collaborative care. When we think about the case, this is an individual who ended up being treated non-operatively due to the mild DCM, but monitored for symptom progression. They collaborated with the spine surgeon, and they underwent surgery and completed pre- and post-operative rehab as their myelopathy did progress. And after surgery, they did achieve meaningful clinical improvements. So just some questions to think about for discussion is, do you recommend pre and post rehabilitation for cervical radiculopathy and DCM? What's involved in your clinical decision-making process? Do you assess patient expectations prior to surgery? And how do you discuss and manage patient expectations following surgery? Thanks very much for listening.